Hello, everyone. Good evening for those joining us live. It is just 1 minute after 7 p.m. Eastern Time. Thank you for joining us tonight for the Canadian Liver Foundation and the University Health Network Ashmere Transplant Center webinar series on liver disease and liver transplantation. My name is Nat Maximovich, and I will be the moderator and host for this webinar. I would like to start by acknowledging that the Canadian Liver Foundation's national office in Markham, Ontario, is situated upon traditional territories of the Anishinaabe peoples and of the Haudenosaunee peoples covered by the Upper Canada Treaties. The Ashmere Transplant Center and the Center for Living Organ Donation at UHN are located in Toronto, Ontario, traditional territory of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and now home to many diverse First Nations, Inuit, and Métis people. Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty, signed with multiple Mississaugas and Chippewa bands. We are joined tonight by two presenters. We have Dr. Gideon Hirschfield from the University Health Network in Toronto, and patient partner, Ms. Jessica Fleming. As for our agenda, briefly, we will have the two speakers complete their talks prior to moving into a question and answer portion. So please feel free to use the comment feed on the Facebook feed to ask your questions during this presentation. And note that questions will be answered following both speakers' talks. This webinar will be available post-event on this Facebook Canadian Liver Foundation page, as well as the UHN page, website, and our various YouTube and social media channels. So for those of you who may not be familiar with the Canadian Liver Foundation, we've been established in 1969. We're the first organization in the world created to help people with liver disease. We are committed to promoting liver health and improving the prevention, diagnosis, and treatment of liver disease through our four core pillars of research, education, patient support, and advocacy. Our partners at the Center for Living Organ Donation were established by UHN Transplant, now called the Ashmere Transplant Center, in 2018. Center's mission is to improve access to living liver and living kidney donation and transplantation. The Ashmere Transplant Center, Canada's largest transplant center, and UHN's Toronto General Hospital is ranked among the top 5 hospitals in the world by Newsweek. At this time, I'd like to welcome our first speaker, Dr. Gideon Hirschfield. Dr. Hirschfield is the Director of Autoimmune Liver Disease Program at Toronto Center for Liver Disease, the Francis Family Liver Clinic, and specializes in primary biliary cholangitis, primarily sclerosing cholangitis, autoimmune hepatitis, and transplantation. Dr. Hirschfield is also the Director of Clinical Practice for Toronto Center for Liver Diseases at the Francis Family Liver Clinic. I will now hand it over to Dr. Hirschfield to take it away.
That's great. Thank you very much for the introduction. So I've been charged with two very important things. One is to give this talk tonight, and the second thing is I'm in charge of sharing the screen. So I'm gonna do my best to do good service to both of these things. So, really what I'm going to do today is just give you a high-level overview of how I see the world of autoimmune liver disease. And then I'm really thrilled that we have a patient partner, Jessica, who's going to, give her story of living with autoimmune liver disease. And my job is to just teach you about these rare liver diseases that are quite impactful, and for which we have a very close working relationship with the transplant programming, and also we have a dedicated post-transplant liver clinic that I run for patients transplanted with autoimmune liver diseases. These are my disclosures, so you're transparently aware that I work with industry in the pursuit of developing new drugs for patients with autoimmune liver disease so that they have a normal quality of life and a normal quantity of life. So for all of you, when diagnosed with liver disease, the journey can be stressful.
So kiss me and smile for me. Tell me that you'll wait for me. Hold me.
And particularly it can be stressful at the start, when you get the diagnosis, when there's a lot of uncertainty, when you're not sure what's going to happen, when you don't understand what's happening, and you're worried about the future. And I think that's really impactful for our patients. And that's why we hope that it's a journey that we can live and work with you for a long time to take you through from diagnosis through to treatment, through to successful outcomes. Because the questions that arise for patients people living with autoimmune liver disease and their friends and family and carers is, what is the diagnosis? Why me? Why my partner? Why my kid? What are you going to do? Is treatment optimal? And what's going to happen? And we have to think about these liver diseases in the context of all the liver diseases that we look after. And autoimmune liver diseases are fortunately rare, but they're very impactful. But they nestle up amongst a very busy population of chronic liver diseases, patients and people living with viral hepatitis, people with metabolic liver disease, people with alcohol-associated liver disease, and people with genetic liver disease. And autoimmune liver disease is probably amongst the most infrequent. That is almost certainly 10,000 to 100,000 times less common than the major causes, viral, obesity, or alcohol. And the way we think of it is as a family of diseases. And it's a family of inflammation that is attacking either the bile ducts or the liver cells. And what happens is that the immune system decides that the bile ducts or the liver cells are foreign, and the immune system starts to attack it, and you get inflammation. And when you get inflammation, you get dysfunction. And when you get dysfunction, you get symptoms, and you get jaundice, and you get progressive scarring. So PBC is a small bile duct disease, and that's attacking the small bile ducts. Autoimmune hepatitis is a hepatocyte disease attacking the liver cells. And PSC, which is nestling there on the right-hand side of the slide, is a disease of the medium to large bile ducts where you get scarring, fibrosis, stenosis. Now, why do we think they're a family of diseases? It's not just because the same people tend to look after them. It's because when we think about what causes these diseases, there's a number of things behind the scenes that lead to these rare inflammatory diseases. Changes in your genes, changes in the way that your bile ducts are working, environmental triggers. Smoking is a risk factor for PBC. Smoking is not a risk factor for PSC. Socioeconomics, exposure to environmental toxins. And, we always like to talk about the microbiome, the bugs in your bowel, although we admit we don't really understand what it's doing. But all of these factors come together to give you these buckets of diseases, which we then give a name. And clearly all our patients are different, but largely they fit into PBC, autoimmune hepatitis, and PSC. There are even rarer autoimmune liver diseases, which I'm not going to talk about tonight, called IgG4 disease, which is really a topic of another seminar. And these diseases are impactful not just because of liver scarring, but because of the quality of life burden, pruritus, which is itch, fatigue, which is a very difficult symptom, abdominal pain, joint aches. They're rare. In Canada, we reckon that about 2 to 3 people per 100,000 develop PBC every year. And for PSC, it's between half and 1 person per year per 100,000 people. So you can see that, in a population the size of Ontario, for example, you've got 10 to 20 people, maybe more, developing new PSC a year, but that not much more than that. So it's rare. In health, your liver should look like this: smooth, healthy, clean, working nicely. In sickness, as the liver becomes scarred, you develop what we call cirrhosis. And anyone can tell you, just by looking at this image, that this is not a healthy liver. It's knobbly, it's got scar tissue, it hasn't got enough liver cells, and the bile ducts will also be damaged. And when you look really under the microscope, you can see that you don't have the liver cells, you have the scar tissue, you've got changes in the blood supply. So this cirrhotic liver is clearly not an ideal liver for our patients to live with. And no wonder is associated with quantity of life detriment and quality of life detriment. So when we think of these diseases, I just want you to highlight what it looks like under the microscope, which may not happen for all patients. They may not get a biopsy, so that you understand what's happening. And I guess I want you to focus on the left-hand side of this, this figure that we've drawn, where we've got some pictures of what the disease looks like, and then I'm going to show you some real pictures. At the top, we've got PBC. So we call it a lymphocytic cholangitis. What that means is the small bile ducts are inflamed, the white blood cells are attacking the small bile ducts, and they're punching tiny little holes, and the bile leaks out. Now you've got lots and lots and lots and lots of small bile ducts, so this disease can be quite slowly progressive. We see inflammation, we measure that in your blood tests, we treat you. We've done very well with treatments for this disease. And there's in fact more than one treatment. I noticed some of the treatments fell off in the editing stage. And that can make a big difference. For sclerosing cholangitis, PSC, frequently associated with inflammation in the colon, it's much harder. But the bile ducts are surrounded by scar tissue. And that means that the medium to large bile ducts get damaged. And we don't have very many medium to large bile ducts. You've only got one common bile duct, and you've only got one branch of the left and the right, et cetera, et cetera. So the impact can be much more significant. And finally, for autoimmune hepatitis, the immune system really does pick away at hepatocytes, and they can get very sore and very injured. Now, this is what you would see if you actually were sitting with our pathologist today. We had a pathology meeting for our autoimmune liver disease program, and this is what PBC would look like. So this is the small bile duct disease, female predominant. Patients are usually in their 40s and 50s, but sometimes younger. And there's a necklace of white blood cells around the bile ducts causing damage. Now, autoimmune hepatitis is an infiltration of very aggressive lymphocytes attacking the hepatocytes, damaging them, and that's leading to jaundice. PSC is very different. This is inside someone's large bile duct. And I've used the term ulcerative cholangitis because many people living with PSC will know that they also live with inflammation in their colon. And some of you will have been awake while you've had a colonoscopy and would have seen what the inflammation looks like in your colon. Not all of you. And in many regards, when you look inside someone's bile duct with a really tiny, tiny telescope called a cholangioscope, we send our patients to St. Mike's because they really are fantastic at it. You see this ulceration. You can see why it's so sore and so much injury, and why it causes so much challenges. Now, to get these diseases, I'm afraid it's a potpourri of risks plus bad luck. Now, the bad luck is probability that you come across something in the environment at the wrong place in the wrong time, and we don't know what those things are. And then you're made slightly differently, your genes are working slightly differently, your heritage is slightly different or relevant, your age is relevant, and it all comes together. And this is why our patients develop this lifelong disease. You lose the ability to control the inflammation, and it becomes persistent. Now, when we dig a bit deeper and we ask our patients what other autoimmune diseases they have and what other autoimmune diseases their families have, we are not surprised to discover that often in the family there are other people with similar problems. So you can see someone here who's got scleroderma because of the tight scarring around the lips, someone who's got rheumatoid arthritis, and the bottom picture is someone with celiac disease who's gluten sensitive, wheat sensitive. And they share DNA. So DNA is important for why you get this disease. It's not like some diseases like sickle cell or cystic fibrosis. It's very subtle changes in your genes that predispose you. And what happens is you've got subtle variation in your genes, you're predisposed to autoimmunity, something comes along in the environment, that leads to abnormal inflammation, and that leads to how your disease appears, your clinical phenotype. And it's different for everyone because it's like Swiss cheese. It's building up of different risk factors over time, and those risk factors may change, and we may intervene, and your body, in fact, may even try and stop some of the inflammation. And that's why, in fact, our patients living with these diseases have a very big variety of presentations and outcomes. No one person is the same. And the next part of these diseases is the environment is so important. The environment shapes all of us. We don't know what role the environment has in exactly development of autoimmune diseases, but we know that there are toxins out there. And this is just a picture to remind you about how important the environment is. We would all be skinny. I would be skinny if I lived in a non-obesogenic environment where I didn't have access to, Coca-Cola without, which is not sugar-free. And the best example for you to understand the importance of environment is celiac disease. So again, it's just a pretty picture at the bottom to tell you that if you have celiac disease and you eat gluten, then your small bowel is inflamed. If you avoid gluten, the environmental trigger, it heals completely. And so we would love to find out what the environmental triggers are for our diseases, but we're not quite there. And then what happens is we're all different. And this is the analogy, I think, of a bonfire. Okay, and a bonfire needs to catch fire. You need to have a flame. And when you think about autoimmune diseases and the variety of the role of the genes and the environment, there are some bonfires which are made, which are so fragile that a single match will mean it will catch fire. So that's a patient who's got very strong genes and anything will cause it to catch fire. Then on the other extreme, which is probably closer to most of our patients, the bonfire is pretty fire resistant. And the only way it will catch fire is if you douse it in petrol and then it catches fire. So the environmental side of it is really powerful and the gene side of it is much milder. And this is why I think we see a real spectrum in our patients and different presentations and different outcomes, because for all of our patients, there are different levels of genetic risk and different environmental triggers. And of course, the challenge is we don't really understand the environment. So when you become sick with liver disease, you want your doctor to evaluate you and to consider the possibility you've got autoimmune liver disease. It's rare. We have to train our primary care doctors. We have to educate our gastroenterologists to think about it. We have to teach them what the blood tests mean. You might think this is simple, but in fact, we have to spend a lot of time because not enough time is given to liver disease amongst family medicine or even amongst our gastroenterology trainees. Are the liver tests what we call cholestatic, so bile duct, or are they hepatitic, hepatitis? What is the story for the patient? What symptoms do they have? What medicines have they been on? What's their past medical history? Have they got other autoimmune diseases? What's the family got? What other risk factors for liver disease do they have? And then we exclude all the common liver diseases, and that includes more blood tests and investigations such as imaging, and we may need a liver biopsy, but then we reach a diagnosis of autoimmune liver disease and which subtype, and then we know what to do. And from the point of diagnosis to your destination is what we call the treated history. And the important thing for you guys and for us, it can be a windy, long road with bumps and obstacles, but we cannot give up easily just because you come a cropper with a bump. We're there, your team is there to support you to jump over those hurdles and to make a success and to focus on quantity and quality of life. And really, you know, what we try and do in our clinic and other clinics, I hope, is really be, in a sense, your liver family doctor, because we want to treat the whole patient, because success is only the whole patient. The liver is important to us, but we need to try and look beyond the liver to make sure that all of you is a success and be your advocate to make sure that we're always working for your best liver health, but also more importantly for your overall general health. And it's always about how to refine the future. And who would have thought that these four boys would have had such an amazing future? Let me see if I can get it to play. And really, that's really important for us, that you know that it's all about making progress. And for what we don't understand about these diseases, that's where the importance of research, clinical trials, and new drugs are absolutely essential. Because in a number of these diseases, particularly PBC, we have made a difference, and we hope we'll make a difference for the other diseases in time. Oops. So for PBC, I'm going to summarize now what it looks like to have PBC. I'm going to do that for the other diseases as we move into the sort of clinical side of the diseases, and I stop playing with my TikTok. So mainly female patients get PBC, 90% are female, 10% are male. Most patients have a very specific autoantibody, so we know how to make the diagnosis. They may have other markers of disease. We may need a biopsy, but if you do an MRI scan, importantly, the MRI is normal. Patients are frequently symptomatic: tiredness, itch, dryness, abdominal discomfort, joint aches. But we have 3 drugs, and there are another 2 drugs in very late stage development for PBC. And we've made huge progress such that our patients sometimes need a transplant, but in fact, now the vast majority will never need a liver transplant. And we want to do that for all of the autoimmune diseases. Autoimmune hepatitis is a disease that goes back to the 1950s. And the original presentation was of young women who are very symptomatic with joint aches and jaundice, who got better when given steroids. Interestingly, we're now seeing autoimmune hepatitis predominantly in people over the age of 50 who also respond to treatment. And our biggest challenge for autoimmune hepatitis is our patients don't like the drugs that we use. No patient likes prednisone. And really our goal is to try and find drugs which are better than steroids. And autoimmune hepatitis is really quite a complex disease because it could be lots of things. Medications can give you something that looks like autoimmune hepatitis. Infections can give you something that looks like autoimmune hepatitis. And so really autoimmune hepatitis is a mixture of diseases. And really we know it's autoimmune hepatitis when it gets better with steroids. And so our challenge in autoimmune hepatitis is less treating it and more finding drugs that our patients are comfortable taking, because unfortunately, we're not curing you. We'd like to, but we're not. And the other thing about living with autoimmune liver disease, which patients can find quite hard, is things can change over time. You can present in one way, and then over time, things change and adjust. So these are pictures of bile ducts in children who presented with what looked like autoimmune hepatitis on the left, and at the beginning have pristine bile ducts, and over 10 to 20 years, develop sclerosing cholangitis. So we're now learning as we follow our patients longer in more consistent ways that you can see this transition. So it starts off like a hepatitis, but it becomes classical sclerosing cholangitis with inflammatory bowel disease. And that's really important as a patient living with autoimmune liver disease to keep an open mind with your doctor that things change and you reevaluate how you are now, not necessarily how you were 10, 20 years ago. So then we move on to PSC, which really is the most difficult of our autoimmune liver diseases. It's fortunately the rarest. And I like to show this slide because I drew this with one of our really talented medical residents who she's going to be one of our liver fellows. She's going off to the US and hopefully will come back to Canada. But she also used to be a medical artist. So I got her to do this for me. The 6 C's of PSC. It can be covert. It is a cholangitis, inflammation of the bile ducts. It can cause cirrhosis over time. It's associated with colitis. Unfortunately, and really of impact for our patients, there's a cancer risk. And what our patients want is a cure, because our current medical treatments, unlike PBC and autoimmune hepatitis, need to be improved. And we're trying very hard, but because it's rare and because it has a very long natural history, it takes decades and decades generally for patients to progress. It's not been easy for us to make the changes in the treatments that we want, but we are trying very hard. So this is the way to remember PSC, the 6 C's of PSC. And when you live with PSC, and we can talk about this when we come to the questions, there's a lot of fear and uncertainty that can lead to social isolation, and that can then contribute to making physical illness worse. And of course, that's relevant for PBC and autoimmune hepatitis. It's not really specific to PSC. But because our patients living with PSC have fewer options, it can be magnified. So in our program, we monitor our patients, we aim for quality of care, we try and contribute to research locally, nationally, and internationally, and we try our best to understand what it's like to live with this disease and communicate. And that's why evenings like tonight are just so important to us, because we want to ensure that people living with these diseases across Canada are well informed. You then rely on your blood test to see how you're doing, to make the diagnosis and to see where you're headed and whether your treatments are working. And in these diseases, you have a cycle of inflammation, bile duct injury, and scarring. And there's less bile duct injury in autoimmune hepatitis, and clearly there's more inflammation of the liver cells. But for PBC and PSC, there's more bile duct inflammation and less inflammation. We look at your ALT and AST, which measures the hepatocyte injury and the damage that that's causing. We look at your alkaline phosphatase and bilirubin, which measures the bile duct injury. And then we look at your platelets count and your spleen size, which looks at progressive liver scarring and the consequences of liver scarring. And then if you're living with PSC, and more than 50% of patients living with PSC have also got inflammation in their colon, have got colitis, then we are always screening for inflammation and treating that and making sure that our cancer risks are minimized and making sure that your colitis is well treated. And there's lots of approaches to the treatment of colitis. And we encourage our patients to really seek the best and seek the best control. Beyond the liver is also really important to us. We recognize that doctors are not the best at this all the time. You know, clinics are busy, clinic slots are short, they're not long enough, let's be honest, okay? And how you feel is complex, and the liver will drive some of that, and other diseases and other processes and other life stresses will also contribute. But our patients complain of fatigue, of brain fog, they complain of itch, they complain of dryness. That can be dryness in their eyes, mouth, and vaginal. They have concurrent autoimmune diseases, celiac, rheumatoid, lupus, Sjogren's disease. It can affect your bone health and put you at risk of bone fractures. You can live with unexplained abdominal pain. So sometimes the pain is explainable, but sometimes it's just discomfort that is, you know, discouraging, intermittent, but reduces your quality of life. For those patients, particularly with PSC, who've got colitis, they have to live with the consequences of colitis and sometimes surgery, be that a pouch or a stoma. Particularly for patients living with PSC, there's a risk of cancer, and this causes a lot of concern, understandably, for patients and for their clinicians. I talked to you about the side effects of treatments, which we're not happy with, and our patients are particularly not happy with. And often they're so unhappy, they won't take the medicines because they don't like the side effects of steroids or the concern around immunosuppression. Pregnancy and intimacy are very important. These are lifelong diseases. We have patients diagnosed, you know, from early in their childhood all the way up to 85. And this takes them through all of very important stages of their life career. And, you know, not being well and having chronic disease can be very impactful for all sorts of reasons at all sorts of times. And finally, where we freely admit to needing more help is, you know, living with the consequences of chronicity and mental health. Now, this isn't directly linked to how your liver's functioning, but this is the reality of living with chronic disease, and learning how to cope with uncertainty and learning how to cope with diseases that not only can impact quantity of life, but don't always, but can definitely impact quality of life, and quality can trump quantity quite often. And we see the whole spectrum. And that can also be challenging for patients. Some patients have no symptoms. Okay, that's great. And they're not sure that they really understand what other patients' experiences, whereas other patients are more progressive and have more symptoms. So with that, I'm going to summarize for each of the three diseases what I think are the 5 key points that you can advocate for when you see your clinicians. For PBC, and you'll notice they're very similar. Have a confident diagnosis is so important. With the right diagnosis, you get the right treatment. Have the first-line treatment in PBC, which is called ursodeoxycholic acid, because it works. Manage your symptoms proactively with your family doctor, your GI, your liver doctor, and tell them about how you feel. Understand your risk as an individual. Is my disease mild, moderate, or severe? And know that for PBC, we've made huge progress in the last 10 years in treating the disease with other drugs such as obeticholic acid, bezafibrate, and there are 2 new drugs in development which are going to become live in the next few years. For autoimmune hepatitis, again, you want a clear diagnosis. This is a bit harder. It's a much more complex disease to diagnose, actually, but you want your GI and your liver doctor to get it right. Control the disease, do one thing at a time. Use immunosuppression because honestly, it makes you live longer. But remember, the patient's the goal, not the blood test. So you can compromise if there are treatment side effects. Again, side effects of treatment and living with the disease include symptoms for patients, fatigue, and patient support groups can help. We manage the complications of cirrhosis, and we look for variant presentations. And finally, for PSC, the most complex of the disease is, number one, you can usually have a diagnosis by MRI. You usually don't need to have an ERCP, which is when you use a telescope to look at the bile ducts. You will need a colonoscopy, I'm sorry to say, but you will. You don't usually need a biopsy, but some clinical trials, it's very helpful, and for research, it's sometimes used. We need to explain the risks and the choices to you because this is a very long disease to live with. Some of the drugs that we use are slightly controversial: ursodeoxycholic acid, vancomycin, when to have an ERCP, how to look after the colitis, when to have a transplant. I was always taught, and I always practice, never too early, never too late for transplant. That's easy to say, takes a lot more experience to just do that for the individual. Again, we recognize the symptoms. And remember, PSC is slightly different to the other autoimmune liver diseases because it's male predominant. And let's face it, men don't go to doctors normally, and men don't normally disclose symptoms. We have to honestly tell you about cancer risks, tell you that the majority of patients will not get cancer, but we'll definitely go looking. And we've really got to encourage our patients to be patient participants in our research if we're going to make a change, and if we really are going to do what we've done for other diseases and move towards control and cure. And we're only going to do that with your help. So with that, I'd like to say thank you. This is our team in different formats by different graphical design at Toronto Centre for Liver Disease, our autoimmune liver disease program. And I hope you found that to be a good introduction. It's not meant to be comprehensive. And I'm now really, really thrilled to be able to hand over to Jessica. I think I'm going to move to the next slide, Jessica. I am privileged to have known Jessica, I think, since 2007 or 8. Which is a very long time, and I'm privileged to have been her physician. And so I'm really thrilled that she volunteered to talk to us tonight, because she really has a great story to tell us.
Thank you so much. Go ahead.
No, thank you, Dr. Hirschfeld. I just want to do a quick intro, Jessica, if you don't mind, so we get it for the speakers, for the audience members, and then you kind of jump right into it. Just let everyone know here on the audience members that Jessica's been a patient advocate for quite a little while now, and she's located in Toronto, Ontario as well. And she's been diagnosed with PSC, primary sclerosing cholangitis, since 2009, actually, and just recently received a liver transplant in 2020. And echoing Dr. Hirschfield's words, we're happy to have her here with us tonight, sharing her story. And of course, she's going to be touching on some of her aspects of her journey, what she's kind of lived with, and I'm sure there's going to be some questions later on for Jessica as well. So I'll hand it over to you.
Thank you so much. And thank you, Dr. Hirschfield. I believe the privilege is mine to have you as my physician. So I'll share a bit about my story and my journey with PSC. I really appreciate the opportunity to share today, so thank you for joining. As mentioned, my name is Jessica, and as you can see on the slides, there are a few pictures of me at different points in my life. One was of a few months before transplant. I'm with my niece and nephew. I'm obviously very jaundiced. The middle is of me this past January in New York City as a healthy 3-year post-transplant patient. And the third is of my donor, Palma, and I on our 1-year liver transplant anniversary. I was diagnosed with primary sclerosing cholangitis in 2009 when I was 25 years old. And as mentioned, I was diagnosed by Dr. Hirschfield. My symptoms began when I started to feel incredibly itchy on my hands and my feet. The itch was unrelenting and it was very distracting. And at first I thought that I had caught some sort of a rash from a yoga mat at the gym, so I began taking antihistamines. When that treatment didn't help, I followed up at a walk-in clinic and they gave me a prescription for antihistamines. Unfortunately, these did not ease the discomfort either. And during this time, I began to lose weight rapidly as well. I had no appetite and I felt nauseous more often than not. Over the next few months, I had many, many visits to the emergency room and was even told I had scabies, which I did not, to try and explain the itch. And I became increasingly frustrated. And finally, at one of the trips to the ER, they decided to take some blood, realized that my liver function tests were a bit elevated, and looked at my gallbladder for the reason. And finally, the radiologist recognized that I was actually suffering from something more serious than an inflamed gallbladder, and I was sent to hepatology. At this point in my life, I was 25 years old. I had never had so much as a cavity, and I was very, very afraid. Although Dr. Hirschfield was incredibly understanding and thorough in explaining my diagnosis of PSC, it was too much for me to comprehend all at once, and I could only focus on how much my life was going to change and the fact that a liver transplant would likely be in my future. It was incredibly overwhelming for both me and my loved ones. I leaned a lot, on my family and friends for support during this time. I took a break from university and I began a therapy to help me to learn how to cope with my anxiety about having PSC. I was also treated for the itch and subsequently for the acute cholangitis that had been the cause for all my weight loss and nausea. Over time, as I started to recover physically, I was also able to come to better terms with my diagnosis. All I knew for sure was that with this disease, it would be an unpredictable progression. For the next 11 years, the years between diagnosis and transplant, I experienced all kinds of ups and downs. Life was wonderful. It was also scary, and it was sometimes very hard. Having an autoimmune disease can be like that. I had periods of health where my PSC I had periods of health, and then I had periods where my PSC would flare up. I ran a half marathon. I met my husband. I started my career. I founded a charity. I moved provinces, traveled, and had many months and years where PSC was quiet and lived in the back of my mind. I also had times where I wrestled with it both physically and emotionally. I suffered from acute cholangitis numerous times and would be treated with Cipro. Sometimes I would end up in the hospital for a few days on an IV to deal with my biliary infections. There were a few times when biliary stones showed up on my yearly MRIs and ERCPs were done to help open my ducts so that the stones could pass. I developed pancreatitis after one of those scopes and spent several months off of work because of it. Over the years, my color began to worsen and jaundice set in, first a tinge and then very deeply. It made me incredibly self-conscious in public and especially at my job. I had many run-ins outside of my specialists with physicians who were unfamiliar with my condition. And oftentimes I was more familiar with what was going on in my body than they were. It is important in these times to advocate for yourself. I have had instances where doctors wanted to do surgeries or treatments on me that were unnecessary and unsafe. I once had an ER doctor who thought my issue was not PSC, but simply a gallbladder that needed to be removed and was ready to wheel me into the OR. I have had other doctors ask me to interpret my own results. My insistence that they speak to my hepatology team before treating me has prevented a few near disasters, so I encourage you to do the same. Your hepatologists and transplant physicians are only one phone call away. Please encourage those treating you to connect. PSC and I had a complicated relationship. Sometimes we got along just fine, and other times we were worst enemies. I had to learn to live my life fully, but to accept and make space for my condition. I had to learn how to make my mental health a priority and would continue therapy throughout my journey to transplant, and I still do. Financially, I realized that I would have periods where I may need to take extra sick days or time off work. Sharing with the Human Resources Department was helpful in navigating that. I also encourage PSC patients to keep savings accounts for times when income may be affected. I began to understand how to listen to my body. I was a young woman who loved being social. Sometimes I had to sit out for a night with the girls or a concert in order to allow my body to rest. It was not, and is still not, always easy, but it was necessary for me to take care of myself in order to feel my best. On those days, lots of sleep, a movie, and a cup of tea would be my medicine. I recommend anyone who deals with chronic illness have a few key support people in their life who they can be honest with about how they're feeling, someone to share the weight because it can be overwhelming to hold onto alone. I've had a few mentors over the years who were further along than I was in their PSC journey. One friend in particular reminded me to make sure that I still take care of the rest of my body. Don't forget to do regular dental visits, mammograms, and physicals. We PSC patients can sometimes be overwhelmed by taking care of our liver health, and it can be easy to neglect other parts of our health care. I also found that to be valuable and important advice. Life can be full of incredible lessons, self-discovery, new perspectives, and newfound strengths. Living with primary sclerosing cholangitis wasn't all scary and bad. It was simply a part of my journey. My health continued on with the expected ups and downs until 2019, when I became very sick very fast. I had decided, along with Dr. Hirschfield, in October of 2019, that it was time for me to begin evaluation for transplant. Thankfully, I was well on my way through the testing process when in late November, I became acutely ill and was rushed to the hospital by ambulance. It was at that point that it became clear my need for transplant was more urgent than initially anticipated. I had been aware for a while that transplant was in the cards for me. I just didn't think I was ready because I was doing pretty well. I was still working and socializing, generally living a pretty full life. But it wasn't until that ambulance ride that I really realized how sick I was. I was extremely jaundiced. I developed ascites, and 7 liters of fluid were being drained from my belly every 2 weeks. I slept most of the time, and when I wasn't sleeping, I was exhausted. I had muscle wasting at that point and had not menstruated in months. My body was shutting down. To my great surprise, the fear changed from the fear that I would need a transplant to the fear that I would not get one in time. In February of 2020, my cousin Palma donated a portion of her liver to me. Since finding out it was time for transplant, she had been sure that she wanted to donate to me and never wavered for a second. Even though she had 2 beautiful young children at home, she really wanted to be the one to give me a piece of her liver. After a few weeks of testing, we found out she was a match, and I have never been through such a broad range of emotions as I was in that moment. I still struggle to put it all into words today. Grateful, of course, relieved, ecstatic for the chance at a healthy life, scared for surgery, and guilty that someone that I loved was going to be putting themselves through this for me. But gratitude was at the forefront, and it would only grow from there. The love I feel for Palma cannot be articulated. She saved my life. The transplant went off without a hitch. Palma was taken into the OR early in the morning, and I a few hours later. It was a difficult recovery, but not nearly as difficult as I had imagined in my mind. I felt better physically from the moment I opened my eyes. I was overcome by appreciation that I had for Palma, my surgeons, doctors, nurses, the porters at TGH, the custodians, PSC and transplant researchers and scientists, my husband, my family, my friends, and the entire PSC community. It takes a lot of people to make a successful transplant happen, and I felt deep appreciation for every single one of them. I still do. Primary sclerosing cholangitis is a very scary diagnosis. It brings with it endless uncertainty. There's not a lot we can control when we're diagnosed with such a tricky condition. We don't know what course it will take for us, and all experiences seem to be very different from patient to patient. All we can control is our reaction to it. I'm not an expert at that, but I am better than I used to be, and I'm always trying. One thing I do know about the PSC journey and living with it is that I'm not alone. There are many who have been there before, many who are going through it now, and there's comfort in that. And as we, the patients and the doctors who work tirelessly with us can come together, we can hopefully uncover more ways to navigate and thrive while living with autoimmune liver disease. Thank you so much for your time.
Thank you, Jessica, for that wonderful talk and really putting definitely a face to the condition. And it's really showing what some of the challenges are with living with a condition with chronic disease as well. So really appreciate you sharing that story. And thank Dr. Hirschfield for that wonderful talk in a 30-minute time frame. I know it's not always super easy to get to cover all those 3 complex conditions in 30 minutes, but we definitely feel that most of our audience members have gotten a great depth of knowledge on this, and they're going to be able to access this talk moving forward as well. So we're going to some questions. We received a few of them online, and we've had a few that were submitted from the participants earlier on. So a few of them are relating to clinical trials. So I'll ask Dr. Hirschfield, I guess the question on the clinical trial specifically was, why are some people, and in this case, the individual mentioned autoimmune hepatitis and PSC, ineligible for many clinical trials? And do you foresee this changing in the future? Or perhaps what maybe some of the challenges are with eligibility in clinical trials?
Yeah, it's a very good question. So, I mean, clinical trials are incredibly hard. They're hard for patients, they're hard for investigators, and they're hard for the people paying for them, our industry partners often. Sometimes we run the trials, but often run by industry. And the way it works to develop a new drug is there's a journey from safety to does the drug work, and does the drug work in the short term to the medium term to the long term. And at each stage, you're trying to get a win to move forward or a clear answer to stop. And we don't want to stop developing drugs that are good, but we definitely don't want drugs that don't work to be tested anymore. And what that means is that when you develop clinical trials, you have very strict rules about who can enter and who can't enter. And you have to have those rules because clinical trials are not supposed to be as diverse as clinical practice, because if they were, we would never prove that a drug worked. And so that's why it can be frustrating for patients when they're being considered for clinical trials to find out that they don't meet the eligibility criteria. But the reason for that is that we want success. And if we allow clinical trials to be too, what we call heterogeneous, too different, too diverse, we won't be able to prove that our drug works. Because every time we do a clinical trial, we're persuading, patients, our ethics, the people paying for it, that it's the right thing to do. And a clinical trial can cost, tens to 50 millions of dollars to do at phase 2, and at phase 3 can cost hundreds of millions of dollars. So we're trying really hard only for success, both in taking drugs forward that work and stopping drugs that don't work. And that means we have to have very, very careful design of trials. And in fact, clinical trial design is a science. There are world experts around everywhere, the globe, including in Toronto, who really know how to develop studies, how many patients to include, how long you should look for, how many doses of drug to try, what the endpoint should be. Because at the end of the trial, you take the data to your regulator, Health Canada, FDA, and you ask them, will you give me permission to sell this drug to patients living with this disease? And you have to convince the regulator, who is neutral, and is neutral for a good reason, because their job is safety first and efficacy second, that you have a safe drug that makes a difference. And the people who do this evaluation, Health Canada, FDA, are very smart, but very fair. And they have a very high threshold to make sure that the drugs that they approve are safe and work. And for that reason, it's not a free-for-all. It's taken very seriously, because we really do not want to lose the trust of patients and families by developing drugs that don't work. We really want to keep the trust of our patients high. And that's the reason why it's arduous to do trials. And there will be times when it's frustrating for patients because they can't enter the studies.
Perfect. Thank you for that. Another question here popped up. This one's for Jessica. Actually, it was more of perhaps some of the day-to-day challenges of PSC flare-ups, and what perhaps did you find was the most helpful in terms of either managing or even coping with the condition? Some either practical tips, or for those folks who are either earlier in their journey, or for those who are halfway through.
Sure. So the challenges of living day to day with PSC, I think I could say, a lot of people have different struggles. So some people have incredible fatigue, others struggle with cholangitis. For me, the most difficult thing was trying to decipher between what was an emergency, what was something I needed to go to the hospital for or call Dr. Hirschfield for, and what was just maybe a regular stomach bug or a regular flu. It was important to me to sort of take account of what my symptoms were day to day if I wasn't feeling well. So did I have a fever? Were my eyes looking a bit jaundiced that day? Was my urine clearer or darker? To just ensure that I was keeping my head about me when things were not 100%. Another sort of piece of advice I have for people is it can be difficult to share with friends, family, and especially work. It doesn't always need to be a direct peer or manager that you share with, but the human resources team can help you out if you would like someone to be aware of your condition in case you do have some extra absences and things like that. Also, I think keeping either a journal of of how you're feeling, or a journal of your thoughts and concerns that you have, so that you have those things available when you do have your clinic appointments. Oftentimes our minds race and it can be hard to get to sleep, or it can be hard to talk yourself down. But writing those things out and having the conversations with the people who can give you the proper answers can be very helpful. And further to that, I would say just taking general care of yourself where you can. As was mentioned several times in the discussion, it's really hard to be treated for PSC. It's hard to figure out what you can do to directly treat it, but you do have control over the foods you put in your body, the amount of sleep you get, exercising when you can. Those things will take you a long way when you are needing to heal, or when you are needing to kind of, level up and feel better when you're not. So I would say just really try and give yourself time, be gentle on yourself. And, it's not your fault that you're sick. It's just something you need to pay attention to, include in your life, and move forward.
Great, thank you for that. Very well said. One other question for Dr. Hirschfield in terms of crossovers with certain treatments. So for instance, a treatment for PBC, would that be a treatment that's applicable for PSC or perhaps autoimmune hepatitis, even though that may be a bit different? Are there any comments or anything perhaps you want to add to some of the crossover with some of the treatments? Successes with one condition and perhaps in the future maybe successful with another condition?
So the answer is we definitely do that sometimes. And certainly, as I said, for PBC, we've made huge progress where people living with PBC are infrequently needing a transplant nowadays. It's still important for some, but infrequently. And we have better control of their symptoms, particularly itch. And then that translates into us thinking, will those drugs help our patients with PSC? And we do the clinical trials. It doesn't always translate, but we are very keen to try, and sometimes then to try in combination. It's frustrating for patients because it seems to take so long to develop new drugs, because it is actually very difficult and trials are hard. The diseases are rare. We have to work across the world to get enough patients into clinical trials. But definitely we've tried to learn from cross-fertilization, so to speak. From a PSC's perspective and autoimmune hepatitis, there's lots of new drugs being developed for diseases like colitis, like rheumatoid arthritis, like lupus. And we're definitely also cognizant of that and thinking about whether we can try them in our disease. So for example, we're going to do a clinical trial, I hope, in autoimmune hepatitis, where we're going to take a drug that's used in lupus. And we're going to try and give that drug to patients with autoimmune hepatitis to see whether it helps. Ideally, you need a mixture of different approaches, but at the same time, we need to advocate for funding for research into the causes of these diseases. And one of the things that hampers us is that we don't know the true cause of PBC, PSC, autoimmune hepatitis. And therefore, it's no wonder that we can't have that sort of eureka moment where everything melts away, because we haven't got to the point of really understanding it. So whilst we definitely use the tools available to us, we take drugs that have been developed in other conditions and consider them for our conditions, at the same time, we are waiting patiently for the basic scientists who are in the laboratory doing so-called blue sky research to come to us and say, you know what, PSC is due to this, or PBC is due to that, and this is therefore the treatment that will work. And that remains a very important part of research, which I hope will continue at pace.
Great, thank you for that. Actually, on that topic, there was a question that popped up on overlap syndrome. And perhaps maybe touching on, I know we get some of those questions at the foundation as well, where folks who reach out and use the term overlap syndrome, or wonder whether one condition starts with the other, or simultaneous or unknown. Yeah. Perhaps we just kind of comment on that.
I mean, that's a very difficult question, and even the doctors can't agree what overlap is. But the way I look at it is that there are three main buckets: PBC, PSC, and autoimmune hepatitis. And the most important thing is to find out which bucket are you mainly in. And because we don't know the exact cause, and because people are different, we then do see variations. There are some patients with PBC that's very inflammatory, and it looks like they've got a hepatitis. There are some patients, like I alluded to, particularly young patients with PSC, who present with what looks like autoimmune hepatitis and then becomes PSC, et cetera, et cetera. So overlap syndrome is not a disease of its own right. It's a description of the variation that you have in how you express the inflammation either in the bile ducts or the liver cells. What we do is identify the dominant disease, and we treat the dominant disease as much as we can. And if, having treated the dominant disease as much as we can convince ourselves that there's evidence of a second process, or a second, biological process, then we might consider using the term overlap. recognizing that the terminology is not great, because quite often what it is treated disease and then a second autoimmune disease on top of that. And I would say that if the term overlap is being bandied around, then you really want to be seen by a hepatologist in a big center, because it is rare, and you will be the beneficiary of more experience if you go to a bigger program. Because I can only be a hepatologist and do a good job because I have a pathologist who's very experienced. I have a radiologist who's very experienced. I have a clinical biochemistry lab who've got access to the latest tests. I have access to the best genetic testing. And so the opinion I give my patients is really based upon the opinions of lots of people. And I wouldn't be able to give that opinion if I didn't have their support and their collaboration. And of course, I forgot to mention, surgeons as well, who are just phenomenal. And so when you're getting into the minutiae, so to speak, and the rarer presentations, you're really going to benefit from the group expertise that the bigger hospital will offer you.
So we have time for just one last question. With respect to the transplant process, it's probably a very hard question to answer, but generally speaking, for the folks who are inquiring on what the journey looks like before somebody would get a transplant, is the disease or any of the three conditions, is the progression between any of them more severe than others? With folks with PBC generally live longer, or maybe less progression than folks with autoimmune hepatitis, or has there been changes in some of the trends over the years? Perhaps just quick comments on that.
So, I mean, nowadays, if you have autoimmune hepatitis, it's very rare to need a liver transplant. So that's good. Our treatments are very good, and the vast majority of patients who are treated well by an expert center will not need a transplant. For PBC, we've made huge progress in identifying the patients who need the most treatment. And we have now got very good drugs that the rate of transplantation is going down. So again, the number of patients in our clinic with PBC who need a transplant is falling. For PSC, it remains a lifesaver. It is true to say that for 50% of patients, 10 to 15 years approximately after their first symptoms living with PSC, they may need to consider when to have a liver transplant. So it remains absolutely life-saving and really important. So the biggest group of patients needing a transplant amongst our autoimmune liver disease patients is PSC, but there are selected patients with autoimmune hepatitis and PBC who still need it. And this is why it can be difficult diseases, because you live with these diseases for a long time, and you may have relatively plain sailing for a long time. And then, so to speak, you'll have a lot of activity in the last few years before you need a transplant. And that's where being connected with an experienced gastroenterologist and hepatologist is important, because they will recognize that turning point in how you feel, that turning point in your scans, that turning point in your blood tests, MELD score, and they will advocate and help you enter the pathway to transplantation at the transplant centers, Toronto, Montreal, London, Vancouver, Edmonton, Halifax, if we're referring to Canada. Yeah, and to enter that journey at about the right time, because transplant assessment is tiring, it's arduous. As I said, you don't want to be early, you don't want to be late. And it's not just arduous physically. I think Jessica described it. It's arduous mentally. Okay, so we want to get that. We want to just time it correctly, but then working collaboratively with the transplant assessment process and the transplant hepatologists, we'll be able to guide our patients to the right point. And it's true to say tonight's talk is, sponsored by the Center for Living Organ Donation. So in Canada, in Toronto, we would be lost without live donor transplantation in liver disease. It is absolutely life-saving. It is phenomenal. It is amazing that we have, friends, family, and anonymous donors who are prepared to be, live donors to save. It's, to be clear, to save the lives of our patients living with autoimmune liver diseases across all three. And it's testament to phenomenal surgeons and anesthetic colleagues and intensive care colleagues that we've got to the point where we've minimized the risk to the donor to really ridiculously small levels of risk, which is amazing. And we've maximized the benefit to the recipient. And it's because of the expertise over decades to reach there. So, transplant is important. It's relevant to some patients more than it is to other patients. And, you know, the process and the support around it have really become much more sophisticated. And that's why our outcomes have got better and better. It doesn't end with transplant, it's just a beginning. That's why we have our dedicated autoimmune liver disease transplant program in Toronto, which we run, you know, so that we continue to look after our patients, because now they've got, you know, they've still got their disease in the sense why they got the disease, but they've got the new challenges of living post-transplant. But really, it's aspirational, because, you know, we're so excited that they've started the journey, get the transplant, and can think about their new life and the new opportunities.
Great, really appreciate that final answer. Okay, we're at time here for the webinar tonight, and that concludes it for this evening. I'll just take the time to thank both our speakers, both Dr. Hirschfield and Jessica, for their great and impactful and friendly presentations. And definitely, it's going to be a huge benefit for the viewers. And again, with the recordings available, please feel free to check back onto this webinar to essentially expand your knowledge and learn from the experts in the field. So I want to thank our partners at the UHN Alzheimer's Transplant Center, of course, and the Center for Living Organ Donation for helping with this series. Again, as mentioned earlier, it will be available on both the CLF Facebook page, website, along with social media channels, as well as the UHN website and YouTube channel in the next few days. So to learn more about liver disease or to find out about the Canadian Liver Foundation, our website is liver.ca. And please be sure to follow us on our social media for all the most up-to-date information and liver health tips. And additionally, for information on transplant and living organ donation, you can visit the uhnTransplant.ca website. So once again, I want to thank everyone for attending. Until next time, take care.